Thank you very much. I think together we can make it to 8:30. I will need your energy and your support to get there, but I think it can be done. I'm going to go quickly for the beginning of the presentation because you've seen it before a short time ago. We'll discuss the value of ultrasound to diagnose acute pelvic pain. We'll describe an ultrasound technique. We'll identify conditions should be considered when the uterus and ovaries are normal. Again, we've been through this before. Acute pelvic pain is very common. It's significant in young women. It's challenging to diagnose. We need imaging to help us, and you now know my views on ultrasound as the first choice, and you know the reasons why. I'm not against CT. CT is a wonderful test if ultrasound doesn't solve the problem in a time-efficient fashion, and we all know the value of MRI, but at least in our practice, it's not readily accessible. So here's our young woman again with acute pelvic pain. You know that in Toronto today, this young woman will likely get a pregnancy test and an order for a pelvic ultrasound. If it's positive, rule out ectopic pregnancy. If it's negative, usually the history says rule out ovarian cyst. So what do we do if the uterus and ovaries are normal? We keep looking. If the ovary shows a simple follicle or a minimally complex hemorrhagic cyst, what do we keep looking? And this is really what this presentation is all about, is this aspect of looking beyond the uterus and ovaries in young women with acute pelvic pain. But that begs the question, well, what are we looking for? Well, there's a whole array of conditions: acute appendicitis, acute diverticulitis, renal colic, and so on. But I call these three the common culprits. So when the uterus and ovaries are normal, and I go in to talk to that young woman, in my mind, I'm saying, could this young patient have acute appendicitis? If the patient's a little older, although in Toronto at least, we see acute diverticulitis now in 20 patients in their 20s. Or is it a renal colic? Is the patient rolling around? Is it flank pain, etc., etc.? So I like to go in and talk to patients from the emergency room with acute abdominal pain, because I find I learn a great deal from doing that. So we now know what we're looking for, and that begs the question, well, how do we look in a time-efficient way? And the first tip I would give you is that if the pain and tenderness is well localized, that's a really good place to start looking. So ask the patient, can you put your finger on the tender spot or where the pain is? The finger goes on, and I would follow that quickly with the probe. I know some physicians who actually give the patient the probe and say, can you put the probe on where you think the problem is? And they start there. If that doesn't solve the problem, then anticipate the common culprits, so appendicitis, diverticulitis, and renal colic. And I've tried over the years to train myself to try and look for these things in some kind of time-efficient way, so that I'm not in there for half an hour or 20 minutes. And then if that doesn't solve the problem, I do a quick, more general survey, and then if enough time has lapsed, I just say, well, maybe I'm not going to answer this with ultrasound, and I'll give the emergency physician a call, and then there's some discussion about whether or not a CT scan should be performed. So how do I look for acute appendicitis? So we'll start with a little bit of anatomy. We all know that the appendix is a blind-ending tubular structure that arises from the cecum, and it's aperistaltic, so you should not see peristalsis. If what you're looking at, peristalsis, it is not the appendix. The origin of the appendix has a fixed location to the ileocecal valve. It's the only predictable thing in the right lower quadrant. And that location is about 2.5 centimeters into the cecum from the ileocecal valve, slightly more posterior. The ileocecal valve we recognize because it is a valve. Dr. Mann alluded to it earlier when she reduced the intussusception. Remember, she spoke about the valve sticking into the cecum. So the appendix doesn't do that. The ileum does. There's a valve. So you can recognize the ileocecal valve with ultrasound. Now, what we have to remember is the cecum's on a mesentery. So while the ascending colon has a pretty predictable position and orientation, the cecum has a mesentery. That's why we can get a cecal volvulus. So the cecum is mobile, and the degree of mobility varies from patient to patient. Not only is the cecum mobile, but the appendix itself is mobile. So the appendix has a mesentery, and it can lie in a retrocecal location, it can lie lateral to the cecum, but most often it lies medial to the cecum, and often, particularly in young women, will drape down into the pelvis. So then what do? I go in, I talk to the patient, I take a bit of a history. Do I think from the history that acute appendicitis might be possible? Gives you some clue as to how much time you might spend. And then I get lots of warm gel, a curvilinear general purpose transducer. I put on lots of gel, and I start well away from the point of tenderness. And my sole goal with that general purpose transducer is not to find the appendix, but is to find the cecum. And I know that the ascending colon is retroperitoneal, usually on the right side. It's the most lateral gas-filled bowel loop that runs vertically down the right flank. And that's what I try to find in transverse. And then I follow it down, and I hope that I can see it end somewhere in the right lower quadrant, suggesting that the cecal pole is high. If that's the case, I have a very good chance of finding the appendix. What happens sometimes, unfortunately, is you follow down, and you realize that the cecum is deep in the pelvis, often sitting on the bladder dome, and then my chances of finding the appendix, at least suprapubically or transabdominally, are greatly diminished. I do that very quickly. It only takes probably less than 30 seconds, and then I have some idea of what I should do, and then I quickly change over to a linear, higher frequency transducer. And my first goal is to identify the medial wall of the ascending colon. And then I scan down along that, and I try and identify the ileocecal valve. And once I identify the ileocecal valve, I know that the origin of the appendix will be about 2.5 centimeters more distally, and I follow down along the edge of the cecum in the hope that I will be able to pick up part of the appendix. And all the time, I'm trying to push the cecum high and lateral, because if I can control the cecum up here by pushing the rectus abdominal muscle back on the psoas muscle, I have a good chance of trapping the appendix draped across the psoas muscle, and I have a very good chance of being able to assess it well with ultrasound. So that's the goal. It isn't always that simple, but that's what I try to do. Now, a little bit about the ileocecal valve and the appendix. So there's the cecum, there's the appendix, same patient, there's the cecum, there's the terminal ileum. If you look at how the appendix comes off the cecum, there is no valve. If you look how the terminal ileum comes off the cecum, there's a valve. That can be very helpful if you're unsure about what you're looking at. Because in the ideal situation, you want to try and scan the entire appendix. So you'd like to see it arising from the cecum, and then you should scan it always in transverse all the way to its tip. And then you scan off the tip, back on, and you know for sure you're looking at the appendix. It's aperistaltic. And then you can make a decision, better with ultrasound in my opinion than CT, whether or not the patient has acute appendicitis, if you're seeing the appendix well. That's the ideal situation. So, here's an example of a normal appendix. Note here, we have the psoas muscle, we have the rectus muscle. We've trapped the cecum up and high in the right lower quadrant. This appendix is trapped. It's attached to the cecum, and I have it trapped medial to the psoas muscle and the rectus muscle, and I'm scanning it in transverse all the way to its tip. It's completely compressible. That appendix is just about 2.5 millimeters in AP dimension. Remember, the 6 millimeter rule is for compression sonography. You will frequently see appendixes on CT measuring up to 9 millimeters in patients who are having CT for some other reason. So that 6 millimeter measurement is with compression sonography. There's no thickening of the appendiceal wall here. There's no dilation of the appendiceal lumen. There's no inflammation of the periappendiceal fat. Here's another example of a normal appendix. Again, we've tracked it. We can see it beautifully. You can see the layers of the appendiceal wall. We're scanning it all the way down to its tip. It's compressible. There is a little bit of free fluid here, but you'll note that there's no periappendiceal inflammation and there's no inflammation of the mesoappendix. In fact, this patient had acute cholecystitis, and it was just easy to find the appendix, and we were able to get a nice simile of a normal appendix. The patient wasn't tender in this location. And here's an internal ultrasound showing a normal appendix that couldn't be identified suprapubically, and over time I've come to realize that the appendix often lies medial to the right ovary and behind the broad ligament. This patient has a little hemorrhagic ovarian cyst. We talked about that in the last lecture. Here's the appendix. It's only about 2 millimeters in diameter, and we follow it to its tip, and it disappears. Now, here's an acute appendicitis. So exactly the same technique. This appendix is thick-walled. It has an AP dimension of about 9 millimeters with compression sonography. And look carefully here at this sail-shaped echogenic fat. Remember, we talked about inflamed fat being echogenic, non-compressible, tender. So that's inflammation of the mesoappendix, and this patient also has some free fluid. And importantly, again, we're scanning the appendix in transverse all the way to its tip. You can confidently make a diagnosis of acute appendicitis. Here's an acute appendicitis. This is all we could see transabdominally, peristaltic bowel loops. We knew the cecum was quite deep in the pelvis, so we went on to an internal scan, and using that we identified this acute appendicitis in the right adnexum. Here we're scanning it in transverse all the way to its tip. The patient was quite tender in that area. There is a little bit of inflamed fat. This appendix measured about 8 millimeters. It wasn't compressible. And then you can take a nice sagittal image just to make a good picture of the entire appendix. But if I were to stop that video right there and I just saw this static image, I couldn't be confident that what I was looking at is the appendix. You need it in that transverse scan as a little donut that you follow. It ends, you go back on. You know it's blind ending. This could just be an oblique image of a bowel loop. Here's another example internally. See how that appendix is again sitting medial to that right ovary. We follow it down. It's fluid distended, there's echogenic material, and we're scanning off the tip of the appendix. So acute appendicitis. Sometimes Doppler helps. I don't rely a lot on color Doppler, but it does make a pretty picture. There's the ovary again. Here's the appendix medial to the ovary. I think you can make the diagnosis here, but just like the stone and the gallbladder neck or cystic duct, if you put on Doppler and the whole thing lights up, it adds confidence. And in the back of your mind, think of Crohn's appendicitis. I do like to see luminal distension if it's a run-of-the-mill obstructive appendicitis. But common things are common, and most times this will be acute appendicitis. Now, there are a few other tricks if you're having trouble finding the appendix. This was a case where it was a male patient. The history was very good for acute appendicitis, and I think in some practices, surgeons would just take this patient to the operating room, but I can say in our practice today, nobody goes to the operating room for acute appendicitis without being imaged. I'm not saying that's right, but that's really what happens. So there's a very low threshold for imaging in the emergency room. So what's happening here is this patient has been turned left posterior oblique. The idea is to try and get the cecum to fall towards the midline a little, and then suddenly, see how gas-filled the cecum and ascending colon is? And in this case, we're scanning onto the appendiceal tip. We're following it down, there's an appendicolate there, and then the appendix dives under. So this is a retrocecal appendix that we were able to identify relatively quickly. So the goal is not to replace CT, but the goal, at least in our minds, in our practice, is to reduce the number of CTs so that we're saving a young population some ionizing radiation. Here's another place where you can get fooled. Query acute appendicitis. Look how beautifully we're demonstrating a normal appendix here. It's compressible, it's 3 millimeters, but the really important thing is to follow it all the way to its tip. So you have to follow. We're up to 5 millimeters, we're almost in the midline, and then right superior to the urinary bladder here, we start to identify something. Keep the pressure on, keep compression, don't be lifting and pressing. You'll incite rebound tenderness and you'll let bowel gas back in. I often scan with both hands because this one gets tired. I keep both hands on, you just wait, and then you start to get this image. So this is an acute tip appendicitis. And if you rely just on this image, saying, oh yeah, the appendix is normal, you'll miss the diagnosis of acute tip appendicitis. So only call it normal if you see it all the way to its tip. Here's another example. Most of these images, by the way, are from our technologist team. So a patient came with acute right lower quadrant pain, and no patient leaves the room without us reviewing the images. And I invariably go in at least to speak to patients with acute pain from the emergency room. But an experienced technologist said, you know, I think I've seen a normal appendix, but it's very short and I can't really connect it to the cecum. So I said, So I got up off the chair, went in. The patient had a very good history for an acute appendicitis, and sometimes I think I press a little harder maybe than the technologist, so just scanning suprapubically or transabdominally, I was able to identify this acute appendicitis that was much higher up. And I honestly don't know what that structure in the pelvis is. I don't know if it's part of a normal fallopian tube, but if you're going to call an appendix normal, it's nice to see it coming off the cecum and following it all the way to the tip. So there are pitfalls in just relying solely on ultrasound. Now, the reason you need to scan in transverse, I'll try and demonstrate here. If I scan the edge of that cecum, as I'm demonstrating, we'll get an image like the diagram on your right. It'll look like it could be an appendix in sagittal. And if I scan the appendix in sagittal, I'll get an identical image. So you can't rely on that sagittal image diagnosing an appendix. You then have to scan at right angles, and if I scan the first image at right angles, I'll still get what looks like a sagittal view of the appendix. Whereas if I'm scanning the appendix in transverse, I'll get the little donut. So for me, when a technologist comes and says, you know, it's funny, I saw a normal appendix in sag, but I can't reproduce it in transverse, immediately the alarm bell should go off. And probably what was imaged was the edge of the cecum or ascending colon. And here's an example from overnight call where this was considered to be a normal appendix. You can see the measurement of 4 millimeters, but the emergency doc wasn't satisfied, went on to CT, and there's an acute retrocecal appendicitis. There were no transverse images of the appendix, so what we're seeing there simply is the edge of the cecum rather than the appendix in sag. Now, I'm going to pick the pace up a little bit and show you less common things, but fairly quickly. So this is a mucocele of the appendix. Again, we're scanning from the tip down towards the cecum. You can see the appendix is quite dilated. It's filled with gelatinous material. You can't really say that. The patient did come with some right lower quadrant pain, so this patient did go to surgery right away. There isn't a lot of inflammation here, so again, if you have a hunch that maybe it's a mucocele rather than an acute appendicitis, just like the gallbladder, give the surgeon and the pathologist a heads up, because the surgeon might handle that specimen with a little more care, and the pathologist might look a little more carefully than if they both believe that it's just another simple acute appendicitis. Remember, with mucoceles of the appendix, the lumen's dilated by mucus. The prevalence is quite low at appendectomy. There's a spectrum from relatively benign disease to frank carcinoma. And the idea here is not to say don't operate. The idea is just to say, you know, there's a chance this could be a mucocele, and things might get handled slightly differently than if they believe they're just operating on an acute appendicitis. And then very occasionally we'll see something like a carcinoid. This is a difficult one to make out, but I think the findings are there. There's some calcification, and then we see this thickened tubular structure, and at surgery this turned out to be carcinoid of the appendix. Now, an important mimicker of acute appendicitis is right-sided diverticulitis. These are congenital diverticula that occur in young patients, 20-year-olds, and it's important because the patient should be managed conservatively. If these patients go to the operating room, what the surgeon will see is a normal appendix, and then they'll look around and they'll see a mass, and they'll be worried that the patient has a perforated tumor. And invariably, if these patients go to surgery, they'll end up with a right hemicolectomy. They're most often solitary. They're true congenital diverticula, so they carry all the layers of the bowel wall. They're often younger patients and probably more common in Asian patients in general, although right-sided diverticulitis can occur in anybody. Here's an example. We're looking up here at the ascending colon. There's inflamed fat here medially, and when you look carefully, you can see the inflamed diverticulum here. There's a little fecal lip in that diverticulum that shadows. And you need to be careful, because if that's all you see, you might be tempted to call that an appendicolip and then think the appendix is retrocecal and you can't see it. So you need to try and establish the relationship to the ileocecal valve, and you need to keep looking for a normal appendix so you don't fall into that pitfall. You don't want a right-sided diverticulitis, ideally, to end up in the operating room. And sometimes we will go on to CT if we're unsure. Here we see the same patient with this big congenital diverticulum that's inflamed, and the CT showed a normal appendix elsewhere. Here's another example of right-sided diverticulitis, very similar imaging. The inflamed diverticulum with echogenic fat surrounding it. See how bowel loops are pushed away. And the patient can put their finger on these, you just pop the probe on, and often it'll become obvious as to what is happening. Now, acquired diverticulitis, these are false diverticula, most often in the sigmoid colon, very common. At least in our practice today, low fiber diets. Some people believe a large amount of red meat consumption at young ages leads to hypertrophy of the muscularis propria, and then the mucosa finds weaknesses and pushes their way out, and diverticula develop. And these tics are more prone to perforation and obstruction. Here's a very nice example. Realize that this is a more distant muscularis propria, the submucosa, the lumen of the sigmoid colon, and then on this side, the submucosa is thickened and more prominent. The muscularis propria is thickened and more prominent, and there's the inflamed diverticulum. You can actually follow it out from the mucosa, and then there's a large horseshoe of inflamed fat. And often with ultrasound, this is a very easy diagnosis because, again, the patient can pinpoint the spot. And this is a particularly good image. You can see how close we are. We're using a high-frequency curvilinear transducer. So I'm not advocating that you image acute diverticulitis always with ultrasound, but the fact is, at least in our practice, ultrasound is often the first test. So it's very nice if you can confidently make the diagnosis. Here's another example. There's the lumen of the sigmoid colon. You can see it's in spasm, it's thickened. There's the inflamed diverticulum, and then the inflamed fat, an inflammatory mass around that inflamed diverticulum. And here's the example I showed you this morning. This one's from the hepatic flexure, the inflamed diverticulum at the focal perforation, that little jet of fat, and an inflamed fat all around it. So ultrasound can give you great detail if you can see the abnormality well. Meckel's diverticulitis, it's a true congenital diverticulum, vestigial remnant of the ophthalmomesenteric duct, about 2% of the population, can contain ectopic gastric or pancreatic tissue, usually presents in early life, but we do occasionally see it in adults, presents as an itis or with bleeding, or sometimes with obstruction, or sometimes with intussusception if they invert. And this is an ultrasound we did. We recognized that there was a big problem here, but we couldn't quite understand what was going on. So we don't spend hours in the ultrasound room. We just realize we're not going to solve this one. And then we go on to the CT scan. And when we did the CT here, we can see the inflammation. There's the Meckel's diverticulum there, and there's a normal appendix more posteriorly back here somewhere. We've just gone through it quickly there. So remember Meckel's diverticulitis, and you will occasionally make the diagnosis. Here's another nice example of a Meckel's diverticulitis. You can see this tubular structure coming up off the distal ileum, and the tip's blown off of it. There's a little abscess there with surrounding fat. Epiploic appendigitis is uncommon, but it is important because it mimics acute diverticulitis and acute appendicitis. And it's important because the management is really just conservative management, symptomatic and reassurance that you'll be fine and things will get better on their own. Here's a nice example that came, usually these, in my experience, epiploic appendicitis is usually at the junction of the descending and sigmoid colon, often anteriorly, but you can get them anywhere along the colon. And this is a nice one that mimicked acute appendicitis. We did ultrasound and we saw this little echogenic nodule coming off a bowel loop. We pretty much knew what it was, but for some reason the patient went on and had a CT, which nicely shows this epiploic appendicitis at the deep inguinal ring. And then another inflamed fatty problem is the omental infarct, which is often larger on the right side, usually anterolateral to the hepatic flexure of the colon, and because of that typical location, again gets confused with acute appendicitis. There's discussion about why it occurs, varying blood supplies, and again settles conservatively. And here's a very nice example on ultrasound. Typically, this fat pad sticks to the parietal peritoneum. So if you ask the patient to take a deep breath in, you can see bowels slide deep to it, but it somehow sticks to the parietal peritoneum. That'll be the site of the patient's tenderness, and you do need to look around to make sure there isn't an underlying problem, such as a thickened bowel loop. So again, often these patients will go on to CT, and CT here basically confirms the ultrasound findings and everything else looked normal, including the appendix. And then sometimes it's actually very difficult to tell, is it an epiploic appendicitis or is it an omental infarct? We could take a show of hands in the room if we had a little more time and decide. I initially thought this was probably an omental infarct because it looked quite big, but then I see the central vessel, and I think now I think it's probably an epiploic appendicitis. Do you agree with me? The good news is it doesn't really matter because the management is the same. It's conservative, and this patient shouldn't go to the operating room. So moving on then to the next common culprit, and that's renal colic. So renal colic is different to peritonitis because patients like to get up, they try to walk the pain off, they're rubbing their sides, they're uneasy, completely the opposite to the appendicitis that's often rolled up, often with the right hip flexed a little bit. And so you look, and the first thing I look for is their hydronephrosis, and then if there is hydronephrosis, I try very hard but quickly again to follow the ureter to see if I can identify a stone. And in women, an endovaginal scan again is a very good way to look at the distal ureter. And that's particularly true in pregnancy. So if somebody comes with right flank pain in pregnancy, and there's a little more hydronephrosis than you might expect for the physiologic hydronephrosis of pregnancy, an endovaginal ultrasound will often show the distal segment of ureter very well, and that's the most often the place that a ureteric stone will be seen. So if we look at this woman using an internal scan, she had right-sided pain. Note the hemorrhagic cyst with retractile blood clot. You mustn't assume that that's the cause of the pain. And really, it's often the clinical history that will be the tip, because this patient had symptoms very typical of right-sided renal colic. There was a little bit of hydro. Remember, only a pelvic ultrasound was ordered, but I have a very low threshold to just take a quick look at that right kidney, and there was hydro, and here with the internal scan, the ureteric stone is very nicely visualized with the dilated ureter proximal to it. And here again, we're just showing a little bit of hydronephrosis on the right kidney. There's the dilated distal ureter, and the ureteric stone with a very nice shadow. If you are going to do endovaginal ultrasound in this regard, you have to realize that the ureter sits right next to the probe. So this is the bladder, this here is actually the ureter, and there's the stone, just there with the shadow. Hopefully that video will play again. So the ureter inserts just off the tip of the probe. There it is in transverse. There's the stone and the shadow. So you pick up very small distal ureteric stones. When you're looking with the internal scan, it's also an excellent way to look at the urinary bladder. This patient came, there was a history of hematuria, and here we see this large mass in the bladder, and the question, of course, arises, is that simply blood clot, or is it tumor? And often with ultrasound, we use color Doppler, and we see some color in that mass, but that could be artifact. So always prove flow with spectral Doppler. And here we see arterial flow in that mass, proving that it's a polypoid bladder mass, probably transitional cell cancer. And I showed you emphysematous cholecystitis this morning. This is a patient in the ICU with abdominal pain, and this is an emphysematous cystitis. Note again that reverberation artifact. So be aware of the appearance of gas on ultrasound. And this patient actually, had the CT scan for a different reason and confirmed gas in the bladder wall. Remember, emphysematous cystitis is intramural and intraluminal gas. Usually, it's most commonly E. coli. And in this case, there's a very, very, very strong association with diabetes. Emphysematous cholecystitis, remember, only about 1/3 of the patients were diabetic. Here, the patients are invariably diabetic. And the treatment is to rest the bladder, Foley catheter, IV fluids, and IV antibiotics. Now, we frequently get asked to rule out pyelonephritis with ultrasound, and I think what we're ruling out is an obstructed, infected kidney, because I have very little confidence in ultrasound actually seeing a focal pyelonephritis. But occasionally, if we're aware of it, we may pick up some clues. And here's a nice example where I think you'll agree, if we follow this renal cortex, this area here is more echogenic than this area here. So in a patient with fever and a high white cell count, it's very reasonable to suggest that there may be focal pyelo. The differential diagnosis would be a renal infarct. If you put a color Doppler or spectral Doppler on acute pyelonephritis, remember you'll get decreased or no flow. You will not get increased flow. So the segment of acute pyelo will be ischemic. So don't expect increased flow with focal pyelonephritis in the kidney. And here's the CT correlate where we see this low attenuation wedge-shaped region in a patient with symptoms and signs of focal pyelonephritis. And I'll just give you a moment to test yourselves here. I'm showing you the right kidney and the left kidney. On a busy day, I would just flash by those two images and think nothing of it. But if you look critically at the right kidney here, there is some perinephric fluid. That in itself doesn't make the diagnosis, but when I highlight that region for you and then take it away, you can see that the upper pole of this kidney is swollen and heterogeneous relative to the remainder of the kidney. Endometriosis, I showed you earlier, but it's something, again, look around with the internal probe. This is endometriotic plaque along the sigmoid colon. And this is a sigmoid polyp. this is an interesting case because this patient had a normal colonoscopy 2 years prior to this ultrasound. And if you look carefully here in sagittal, we can follow the sigmoid colon. We're coming up from the rectum into the sigmoid colon, and there's something in the lumen here. And then we look in transverse. We'll let the cine loop play again. Here's the sigmoid colon in transverse. Here's something in the lumen. And then we go past it, and this is what normal sigmoid colon looks like. And how do you prove it? Again, put on color. You see some color. Ensure it's blood flow with spectral Doppler. We see an arterial waveform. So we call this very confidently. The surgeon thought we were crazy, but nonetheless did endoscopy. And there's a picture from when that polyp had been resected. So we're seeing cauterization there at the base of the polyp. Ultrasound can also be very good for Crohn's disease. You'll see the thickening of the wall, typically terminal ileum, but as you know, can occur anywhere. It's very good for the perienteric fat. It's very good for the fistulization, and on the image on your right, there's even a little inflammatory mass developing there. This is an ill patient who's been on antibiotics. They have profuse diarrhea, and this is massive thickening of the submucosa of the cecum and transverse colon. Remember, with ultrasound, you can see the 5 bowel layers. So you'll see an echogenic mucosa. I'll just bring up my little arrow here, this echogenic line. You'll see the hypoechoic muscularis mucosae, then the submucosa, which is massively thickened here, then the muscularis propria as hypoechoic, and then the echogenic serosa. So if you're seeing the bowel well with ultrasound, you'll see all the layers, and the condition that thickens the bowel more than anything else is pseudomembranous colitis. So this is a very typical appearance of pseudomembranous colitis in the cecum ascending and transverse colon. This is an interesting patient who had known systemic lupus, and this is lupus vasculitis. So this is small vessel vasculitis in the bowel, where we see this very uniform edematous thickening of the valvulae coniventes. An ultrasound here actually resolves the individual valvulae coniventes in this jejunal loop, and then you can see the CT comparison. Dr. Mann very nicely discussed intussusception in an earlier talk. We see it in adults, and the appearances are surprisingly similar. You can see the mesentery being pulled in here, and then in sagittal we see the muscularis propria and the intussusception. Where things differ in adults, of course, is that there's invariably a lead point, so there's invariably a mass. So we don't routinely try to reduce these with enema in adults. And when you're imaging them, you should look very carefully for a lead point. And if we follow this intussusception carefully, we follow it down, here's a large mass. And this interestingly turned out to be a GI stromal tumor. As you know, GI stromal tumors more commonly grow. They're submucosal masses, well encapsulated vascular. There's often a central umbilication, and they typically grow exophytic to the bowel, but every so often one will fall into the bowel lumen and act as a lead point. And I call this sign a target sign. I think Dr. Mann called it a donut sign. I think either works well. And because I grew up on a small farm in rural Ireland, I particularly like this sign, the pitchfork or hayfork sign. So you can see there the muscularis propria mimics this hayfork or pitchfork. And then the final case, at least I think this is the final case I'm going to show you, is this woman who had a CT scan with a renal colic protocol to rule out renal colic. And there were no urinary tract calculi, and we were struck by this appearance here on the left adnexa, and we weren't completely sure if that was bowel or if that was an adnexal mass. So she came for ultrasound. The uterus and ovaries were normal, and we could see this very dilated peristaltic bowel in a cluster in the left adnexa, and she was clearly very ill. So again, it's an advantage of ultrasound. She was curled up on the bed. She had very, very significant signs of peritonitis. You even begin to wonder here if there might be gas in the bowel wall. I wouldn't feel comfortable confidently making that diagnosis there. But the surgeons were impressed enough that she didn't return for an enhanced CT. She went directly to the operating room, and she had dead bowel at the time of laparoscopy. And then actually there's one small section, free air. I'm not suggesting for a moment that you use ultrasound as the primary way to diagnose free air. But again, often ultrasound is the first examination that we do in our practice, and so you should at least be aware of what it looks like. If a patient has free air and they're lying supine, the free air will be here in the epigastric region, and then it's a bit like a spirit level. As you turn the patient and wait, the free air will rise to the antidependent area. So if the patient is left lateral decubitus or left posterior oblique, you can see air up over the liver. And you saw a nice example of that this morning. This is what it looks like, this focal enhancement of the peritoneal stripe, separate from bowel with reverberation artifact. And then we see it in the right upper quadrant here. A nicer picture would be with a linear probe. So if you want to capture a nice picture for a talk, put on the linear probe, and you will see it. And this is the patient I showed you earlier from today with the linear probe and that focal enhancement and reverberation. So, just to summarize, ultrasound is the first choice. Remember to keep looking beyond the uterus and ovaries, and if you're looking for non-gynecologic causes, start looking at the point of localized pain or tenderness, and then a dedicated search for the common culprits: appendicitis, diverticulitis, renal colic. Remember, always scan that appendix in transverse all the way off the tip and back on. If you think you might be seeing a mucocele, give a heads up to the surgeon and pathologist. Remember, if you think there's color flow in a mass, confirm it with spectral Doppler. And the goal here is not to replace CT for these patients, but it's to reduce CT and the associated ionizing radiation if we can do it quickly. And where I practice, it's also much more cost effective. We have a universal healthcare system funded by the government. An abdominal ultrasound is 30 Canadian dollars. A CT of the abdomen and pelvis is close to 200. So there's a significant savings to the healthcare system if we can solve the problem with ultrasound alone. Admittedly, if we do an internal ultrasound, it's probably $60 versus $200. So with that, I'm really, really grateful that so many of you have stuck it out, and thank you very much for that. I've really enjoyed my day with you all. Your hospitality is unbelievable, and thank you very much.